Now, in the second section of our lecture, we will specifically talk about the intratemporal complications. I already mentioned that there are two major classifications of the complications of suppurative otitis media in the previous section. One is intratemporal and the other one is intracranial. So in this, we will talk about the intratemporal complications. In this section, when we will talk about intratemporal complications, we will talk about the pathology and what are the different factors that leads to and how the intratemporal complications occur. We will talk about the clinical features and what are the differential diagnosis of intratemporal complications. And then we will also talk about how these intratemporal complications can be managed and treated. So the intratemporal complications of otitis media. In this, the inflammation of mucosal lining of antrum and mastoid air cell system is an invariable accompaniment of acute otitis media and form part of it. So in this, the intratemporal complications of suppurative otitis media, mainly it involves the mucosal lining of the antrum and mastoid air cells. And it is the main part of intratemporal complications of otitis media. The etiology and what are the causes of intratemporal complications of otitis media is high virulence of organisms that cause this infection. If the high virulence or if they are highly pathogenic microorganism, it can cause a serious disease or infection, which is sometimes hard to treat also. So virulence of the organisms, causative organisms, is an important causative factor. Then the low resistance of the patient due to measles and then exanthematous fever, poor nutrition and diseases like diabetes. So as we mentioned earlier in the section 1 also, that what are some of the factors that leads to complications, and one was the virulence of the organism and then immunocompromised patients. So immunocompromised is patients might have diabetes, if they have infections like measles, if their nutrition is not good. All these factors can lead to intratemporal complications of otitis media. And in this diagram, you can see this arrow is indicating the site that is involved in the intratemporal complications. Then usually seen in mastoids with well-developed air cell systems. So all this is the area of the mastoid bone, and it is usually seen in the mastoid area when they have well-developed air cell systems. So this is the here. Next, the pathology of intratemporal complications. The pathological responses are there is production of pus, and this pus is under tension. Remember, when the pus is under tension, the condition is very painful. Patient usually may have present with high grades fever also, fever with chills. When pus is present, usually they have fever with chills, rigors, and there is very bad pain also associated with this. Once the area is abscess is drained, usually that tension is relieved and patient feel better. And then there is hyperemic decalcification and osteoclast resorption of bony walls. So osteoclasts are the cells that cause destruction. Osteo is for bone, osteoclastic are cells that cause destruction of the bones. So there is osteoclastic resorption of bony walls. Then the extension of inflammatory process to mucoperiosteal lining, which increase the amount of pus produced due to large surface area involved. So this is the pathological response or pathology how which the spread of infection occurs. So from the site of infection, it spread to mucoperiosteal lining. We said that it is due to involvement of the mucosa. So when the infection spread to mucoperiosteal region or lining, then there is more production of pus due to involvement of big area. So mainly the pathological process is due to decalcification and erosion of the bone or destruction of the bone by osteoclastic cells. And then there is production of pus under tension. Again, this is the area that is mainly involved, mastoid region. Then the clinical features of intratemporal complications or mastoiditis is pain behind the ear, fever, ear discharge. There is tenderness. Especially tenderness is very, very common when there is pus and it's not coming out or it's not drained. Ear discharge, sagging of posterior-superior meatal wall. So posterior-superior, this is the posterior side, superior, and there is sagging of the posterior superior meatal wall as a result of abscess that put pressure on the posterior superior meatus and that caused sagging of it. Swelling over the mastoid, hearing loss, and some general findings like malaise, tiredness, pallor, fever, and patient is not very, basically it's in the compromised condition and not feeling well. So all these are very common signs and symptoms of the mastoiditis or infection or complications. Then the investigations. Blood count, CBC should be performed in any infections. Usually it shows high number of white blood cells or leukocytosis. Leukocytes are white blood cell. Leukocytosis is the condition of increased white blood cell. So white blood cells are the cells that fight infections. So when there is infection, the white blood cell count is always raised because their number is increased to fight the infection. ESR, erythrocyte sedimentation rate, is another indication of infection. ESR is raised. X-ray of the mastoid can be done, and usually what it shows, there is clouding of air cells due to collection of exudate or pus in them. So when X-ray of the mastoid is performed, it shows cloudiness of the mastoid cells. Ear swab is done for culture and sensitivity to find out the causative organism. Then what's the differential diagnosis? Differential diagnosis is suppuration of mastoid lymph nodes. This is the area of the mastoid. Sometimes when the mastoid lymph nodes are involved, this area is swollen, and when you feel these swollen lymph nodes. That can be a differential diagnosis of the intratemporal complications of suppurative otitis media. So scalp infection may cause mastoid lymph node enlargement and suppuration leading to abscess formation. So that can be one differential diagnosis. Other is furunculosis of meatus. Furuncles are also swellings. When furuncles are present, it can be confused as complications or mastoiditis. Absence of preceding acute otitis media. One very important differentiating point in furunculosis is there should not be any previous history of otitis media or drainage from the ear or pain in the ear. So that's one good diagnostic factor. Painful movement of pinna is usually present in furunculosis. And there is swelling of meatus is confined to cartilaginous part. This is the cartilaginous part of the ear. So usually it is limited to cartilaginous part, not to the mastoid. And then discharge is never mucoid or mucopurulent. Discharge in this condition is maybe serous, but it won't be purulent or pussy discharge. So all these are very important diagnostic factors which can differentiate between furunculosis and complications of the suppurative otitis media. Enlargement of pre or post auricular lymph nodes. There will be enlargement of the lymph nodes also. Conductive hearing loss. Conductive hearing loss because there is a furuncle in the meatus and that is causing obstruction to the passage of the sound waves. So that can lead to conductive hearing loss. Normal looking tympanic membrane which excludes also the acute mastoiditis or acute otitis media. X-ray of the mastoid usually won't show any cloudiness, it will show clear air cell system. Then the other differential diagnosis is infectious sebaceous cyst. Infectious sebaceous cyst also leads to swelling and that can be differentiated in the same area. So differential diagnosis can be from suppuration of mastoid lymph nodes and then furunculosis of meatus and infected sebaceous cyst. And then we have so many differentiating points how we can differentiate furunculosis from the complications of suppurative otitis media or more specifically mastoiditis. There will be clear X-ray of mastoid air cells. There won't be previous history of mastoid acute otitis media. There will be conductive hearing loss. There will be painful movement of the pinna. So all these are the differential diagnosis of suppurative otitis media and its complications. Then the treatment. Hospitalization of the patient. Antibiotics which can be given is amoxicillin or ampicillin. Then myringotomy. Myringotomy is, otomy is the opening and then myringotomy is done and then the tube is placed inside. So this is incision into the tympanic membrane, placement of the tube with forceps and then this is the tube in place for this or myringotomy. So myringotomy, especially to drain the pus when it is under tension. When pus is under tension, cortical mastoidectomy, subperiosteal abscess, sagging of posterior-superior meatal wall, no change or worsening of the patient condition. So these are all the indications for myringotomy when the incision is given in the tympanic membrane. Myringo is for tympanic membrane. Otomy is the opening. So indications for performing myringotomy is if there is abscess, if we have to do mastoidectomy, if there is sagging of posterior-superior meatal wall, and for the drainage of the pus under tension. Complications of acute mastoiditis are the subperiosteal abscess, labyrinthitis, facial paralysis, Petrositis, extradural abscess. These are the complications of the acute mastoiditis, and then subdural abscess. This is all the infection. You can see this is the area of the mastoid. When it is badly infected, it can lead to all these complications. Infection can spread when there is pus inside. It can spread to the different parts. It can cause subperiosteal abscess, facial paralysis, Petrositis, extradural and subdural abscess when it reaches the meninges and the subdural or extradural area. Meningitis when it causes involvement of the meninges of the brain and spinal cord. This is the mastoid, this is the infection, can spread through the blood vessels, and then through the bone erosions different, it can spread to the different parts. So these are all the complications of acute involvement of the mastoid as a result of suppurative otitis media. Remember, we are talking about the complications of suppurative otitis media when it is intratemporal involvement of the suppurative otitis media, and then the first one is acute mastoiditis, and these are the complications of mastoiditis. Brain abscess also can occur as a result of acute mastoiditis. Lateral sinus thrombophlebitis. Otitic hydrocephalus, accumulation of the hydro is for water, cephal is for the brain. It can also lead to accumulation of fluid in the brain. So all these are complications of acute mastoiditis which occur as a result of intratemporal involvement of suppurative otitis media. Next, abscesses in relation to mastoid infection. So once the mastoid bone is involved as a result of suppurative otitis media, then different infections can occur, and that infections can lead to the formation of pus or abscesses in the areas close to the mastoid bone. So abscesses in relation to the mastoid infection. First is the post-auricular abscess. Post is after, behind, pre is before. So post-auricular. Auric is used for the auricle, this area, auricle. So post-auricular abscess. Commonest abscess that form over the mastoid is post-auricular abscess. Pinna is displaced forward, outward, and downwards. You can see the pinna is displaced forward, outward, and downward. This is because of the collection of abscess or abscess formation behind the ear or post-auricular abscess, and this can put pressure on the pinna, and then pinna is displaced forward, outward, and downwards. The other abscess is zygomatic abscess. Again, this is the zygomatic bone that forms the cheek, zygomatic bone, and zygomatic and zygoma. So this is zygomatic abscess. Occur due to infection of zygomatic air cells situated at the posterior root of zygoma. Zygoma, zygomatic arch, posterior root. So if you see, it's very, very close to the mastoid and the ear. So when infection spread to zygomatic air cells, it causes zygomatic abscess formation. Swelling appear in front and above the pinna. So this is basically the area. So zygomatic, this is the zygomatic bone, and when it reaches the zygomatic air cells, it causes swelling in front and above the pinna. Then the other is bezold abscess. Bezold abscess. This is the abscess that occur following acute coalescent mastoiditis when pus break through thin medial side of the tip of the mastoid. So usually abscess occur when pus break through the thin medial side of the tip of the mastoid. So when tip of the mastoid, the pus is released, it leads to the formation of bezold abscess. Lie deep to sternocleidomastoid, pushing muscle outward. If you see, this is the sternocleidomastoid muscle. So when the abscess come out of the mastoid bone, if you see, mastoid bone is very close to the sternocleidomastoid muscle. Sternocleidomastoid is the big muscle. When you turn your neck, you put a hand there. This is the sternocleidomastoid muscle. So lie deep to sternocleidomastoid, pushing the muscle outwards. Follow posterior belly of digastric and present as a swelling between tip of mastoid and angle of the jaw. So this is the area, basically angle of the jaw and the mastoid, and it forms the swelling or abscess. This is the bezold abscess. So these are all the surrounding areas of the mastoid. When pus is formed there and it drains out and it affects the different parts, it can lead to abscesses formation in different regions. Be present in upper part of posterior triangle. So it's present in the upper part of the posterior triangles. This is sternocleidomastoid. This is the digastric muscle. When this pus is drained, it affects these two areas or these two muscles and form a pus at the tip of the mastoid and at the angle of the jaw. So this is the site where this bezold abscess is formed. Reach parapharyngeal space and track down along carotid vessels. So when it reaches the muscle, from there it also reaches the parapharyngeal space, which is around the pharynx, and then it tracks down also the carotid blood vessels. Should be differentiated. If you see, this is the picture of bezold abscess. It's a very, very big swelling here, mastoid area. Sternocleidomastoid muscle is here, and then we have the this is all the area, and then it spreads and then should be differentiated from acute upper jugular lymphadenitis, abscess or mass in the lower part of the parotid gland. Parotid glands are also in the neck, and when they are swollen, it involves roughly the whole area. So it should be differentiated from the enlargement or abscess in the parotid gland. Infected branchial cyst, and also parapharyngeal abscesses. So bezoar abscess should be differentiated from all these different conditions. Acute upper jugular lymphadenitis, then we have infection or swelling of the parotid gland, infection of the brachial cyst, and parapharyngeal abscess. Jugular vein thrombosis, it should be differentiated from jugular vein thrombosis. Next, abscesses in relation to mastoid infection. There is meatal abscess. Example of meatal abscess is like a luck abscess, which pus breaks through the bony wall between the antrum and external osseous meatus. Then we have behind the mastoid, another is known as the Sequelae abscess, which is formed behind mastoid more toward the occipital bone. So occiput is on the back of the temporal, so more towards the occipital bone here, this abscess is formed, which is behind the mastoid. Then also parapharyngeal, which is retropharyngeal abscess, result from infection of peritubal cells due to acute coalescent mastoiditis. So all these are infections which occur as a result of infection from the mastoid or mastoiditis. So you saw so many complications can occur from mastoiditis, and all these areas are affected as a result of infection of the mastoid. Next, mast type or latent mastoiditis. It is the condition of slow destruction of mastoid air cell. Again, swollen area, similar presentations, but it is latent or it's slowly progressing infection or slowly progressing mastoiditis. No pain, discharge, fever, or mastoid swelling. Extensive destruction of air cell with granulation tissue and dark gelatinous material filling the mastoid. Since it's chronic, slow progressing, so it leads to formation of granulation tissue and dark gelatinous material fills the mastoid. Etiology and the causes are result from inadequate antibiotic therapy in terms of dose, frequency, and duration. So, if the treatment of acute mastoiditis is not good or not properly treated, it can lead to latent or masked mastoiditis. So poor treatment is a factor that leads to masked or latent type of mastoiditis. Use of oral penicillin. Clinical features are child not feeling well with pain behind the ear, tympanic membrane thick with loss of translucency, conductive hearing loss of varying degree, and then X-ray shows clouding of air cell with loss of cell outline. So these are all the clinical features, and etiology is inadequate antibiotic therapy in terms of dose, frequency, and duration of administration. Treatment is cortical mastoidectomy, and antibiotics. That was all about the section 2, in which we talked in detail about the intratemporal complications, what are the complications, acute mastoiditis, what are the complications of acute mastoiditis, and what happens if it's not treated properly. Thank you for watching sqadia.com.